If a patient is diagnosed with non-muscle invasive bladder cancer and it is low grade, and this is the majority of patients, it's the least aggressive of the bladder cancers that we can diagnose, which is good. So normally what we would do is, after we have resected the bladder tumour, at the same operation we will put in chemotherapy into the bladder. Just 40 mils of chemotherapy into the bladder, and what that does is it decreases the likelihood of the cancer recurring by about 35%. Okay? Afterwards, the first cystoscopy needs to occur at about 3 months. And that first cystoscopy at 3 months is very important, because if the patient has a recurrence at 3 months, then it means that this patient is likely to have lots of recurrences in the future. If the patient doesn't have a recurrence at 3 months, that's good news, and that means the next cystoscopy will be at 9 months, and if that's okay, then it'll just be once a year until the patient gets to 5 years. If a patient is diagnosed with non-muscle invasive high-grade disease, what that means is that it is a bladder cancer and it is high grade, which means that it can act quite aggressively. Thankfully for the patient, it hasn't yet invaded the muscle, but if not treated properly, it can do that. So what we often do in these cases is go back and do a repeat TURBT, or re-resection of that area. And the reason for that is that often there is residual cancer microscopically that we haven't resected the first time, and it's important to get rid of all of that. The second thing is we take another sample of the muscle to make sure that we haven't missed any cancer that's gone into the muscle. Now, provided that re-resection confirms that the patient still has non-muscle invasive bladder cancer, the next step will be to give a treatment called intravesical BCG. And intravesical BCG is an immunotherapy. It's like a vaccine treatment. And it's a treatment that's given into the bladder once a week for 6 weeks, and then frequently after that, but not as intensively, for 1 to 3 years. And what that treatment does is it stimulates the body's own immune system to kill any cancer cells that pop up. Muscle invasive bladder cancer is a more serious form of bladder cancer than what I've previously described. Once cancer has gone into the muscle, there is a chance that microscopically there could be cancer outside the bladder. There are a number of different treatments for this. The gold standard is what we call radical cystectomy. That is removing the entire bladder along with surrounding lymph nodes. Once the bladder is removed, the urine, which comes down from the kidneys, needs to go somewhere. And we generally have a few different options. First and most common, particularly with elderly patients, is to have what we call an ileal conduit. That is a bag that collects urine, usually sits on the right-hand side of the abdomen. But in younger, fitter patients, we can make a new bladder for them out of bowel called a neobladder. And occasionally we can also do something called a catheterizable pouch, which is like a bag made of bowel, and you can put a catheter in through the belly button to empty the bag. Once cancer has spread beyond the bladder to other sites, it's called metastatic disease or secondary disease. And common sites for the cancer to go to is lymph nodes, liver, lung, and bone. If cancer has gone to those sites, it is not going to be curable, but it is very treatable, and life expectancy can be increased quite substantially with new treatments that we have. The standard treatment is chemotherapy, but there are also new immunotherapy trials that is using immune therapies that are actually working very well in bladder cancer, and there's actually currently lots of clinical trials open to patients that they can enroll in so that they can get access to some of these drugs. Within the bladder, some rare cancers can occur, and this is usually in about less than 5% of cases. The rare cancers that occur most commonly are squamous cell carcinoma and adenocarcinoma. So squamous cell carcinoma often occurs in patients who have chronic irritation within their bladder. And that might be patients who have a long-term indwelling catheter or recurrent urinary tract infections or stones within their bladder. And the type of cancer that occurs, squamous cell, is not that responsive to chemotherapy. So if it looks like the cancer is confined to the bladder, then the best treatment option is a cystectomy to remove the bladder. If, however, the cancer has spread beyond the bladder, then chemotherapy is necessary before doing surgery to remove the bladder. The second type of cancer, adenocarcinoma, again occurs in about 1% of patients, and if it occurs in just one part of the bladder called the dome of the bladder, often what we can do is just excise the tumour and reclose the bladder up again without having to take the entire bladder out. In addition to that, we'd need to remove their lymph nodes. However, in other cases, the adenocarcinoma can be more advanced, and in those cases you need to have chemotherapy before you attempt to remove the bladder with the adenocarcinoma. Second opinions are very important for a patient if they're unsure about which pathway they need to take. Second opinions are also important if a patient is going to undergo major surgery like a cystectomy, because we've got strong data that shows that if you have surgery by a high volume surgeon in a high volume hospital, your outcomes are much better than if you have it with a low volume surgeon or in a low volume hospital.